I'm Dr. Derek Lee. I'm with Dr. Antonacci today. Welcome again, sir.
Thank you.
Dr. Antonacci is the lead orthopedic spine surgeon at the Institute for Spine and Scoliosis in New Jersey and New York. He's one of the founders and pioneers of Anterior Scoliosis Correction, which is a non-fusion surgery for scoliosis. Now, our first interview was almost 2.5 years ago. I believe you had performed about 530 ASC surgeries at that time. That number has grown to almost 800 ASC surgeries today.
That's correct.
It's a phenomenal amount of surgeries, sir.
Yeah.
I'd love to hear more about what you've learned over the past 2.5 years and hope you can share more of your long-term data regarding ASC and disc release.
Yes, and thank you for the opportunity. I feel this is really a critical time to, we've been talking a long time about a follow-up interview and presenting a lot of the data for ASC now. And that's what's been collated here. And I went back and watched our video from 2020, just so I know that I wasn't repeating myself too much. And so I would encourage the viewers to go back to that, because that was a lot of the principles of the concepts of the scoliosis origin and the detorquing, the derotation phenomena that you can do with ASC, certainly compared to metal rods and the original VBT technique. And so what I did with this preparation is I put together a bunch of slides with data, pictures, things like that, so we can dive into that and do a deep dive. I guess the message I want to get out there, though, is very specific. I think we're 10 years into this now, so this is not something that's new. And just like any momental shift that occurs in any field, I think we're really at a momental shift between migrating completely away from metal rods and then to what? Well, I can't stand here and say it's VBT, because to me, VBT is just the first version of what we started with 10 years ago, right? And we just kept making improvements to VBT to the point where it migrated into something called ASC. And so I want to show that comparison to you and your viewers and explain the nature of that and why the data is pointing this way. But that's what this is about. It's really about clarifying the things that are out there in terms of why people are doing metal rod still versus migrating completely to it. And it's a whole process. It will probably take another 5 to 10 years. It's not something that happens overnight, but this is the data that shows why it will happen. So unless you have any specific questions right off the top, Derek, I would bring up the PowerPoint and just go from there.
It's all in your hands, Dr. Antonacci.
Okay, let me share the screen here. Okay, so obviously I can't do this talk without acknowledging my two partners, Dr. Betts, who's been with me for 10 years, and Dr. Cuddy, who's been with me for almost 15 years. But this is ASC by Drs ABC. I think we also need to clarify that too, because ASC being done elsewhere, most likely are by people that I've actually trained. There's a few of them out there, but I haven't trained anyone for 5 years. And so ASC by Drs ABC is a very nuanced procedure that needs to be explained even to other doctors. So, and as I started with earlier, I really see VBT as just the first version. And when I describe ASC to people now, ASC is really the multi-year, multi-generational improvement upon that first technique. Because if you actually get to the nuts and bolts of it and you look just at these pictures, well, VBT is here over on the left, it's screws and a cord. Well, if we go over to the right, which is all the variations now into ASC, it's screws and a cord. What's the difference? It's how you get there, what you do when you can get there, and whether you're limited by VBT versus the nuance improvements with ASC. And that's what's happened over the 10 years. VBT is and still is a single screw at each level, a single cord. And it's because when you work through the technique of VBT, which is a thoracoscopic approach mostly, you can't do much else. You can't save the segmental arteries. You can't release the contracted ligaments along the spine. You can't put more than one screw in. You can't put more than one cord in generally. And migrating up to the anterior scoliosis through the iterations that we've had is really getting to a multi-screw construct, double cords, double screws. In fact, and I'll get to it a little bit later, my current technique is like quadruple cords and a quadruple transition. And so what does that mean? Well, no one knows what that means except the people in the practice here. And But this is what you see commonly now with my technique, which is 2 cords at each level, 2 screws at each level, and variations of patterns. And I've always talked about how, going from metal rod was like going to the flip phone and for VBT, but going from the flip phone to ASC going from VBT to ASC was like going to the first iPhone. And that was basically 10 years ago, right? And so these are all the first. I'm not going to go through this again because we have this in our first interview, but there's some trends here that I wanted to point out, which is, early on, we did a combination of a cord technique in the thoracic spine and metal rod technique. So we called those hybrids, a metal rod cord hybrid. And we did that very early on. And we transitioned up through 2015. It was really very pivotal milestone year for not just a lot of firsts, but also, developing the technique to go to L4 very routinely and very safely. Starting to release the spine in the thoracic area from 1 to 3 levels. Developing stage surgery technique, which has really led to our knowledge of what happens to the disc in subsequent follow-up, and also the ability to address curves that are 95 or 100-degree curves. Migrating from the single cord, single screw technique to double screw technique. That followed through into 2018, really amping up the amount of releasing in the spine from, going up to 3 to 6 levels, starting to dabble into the lumbar spine releases, but certainly solidifying the double screw, double cord technique into 2020 to 2023 right now, which is what I would just lay out there as, quadruple cord technique and quadruple screw transition. Nearly every level from thoracic to lumbar, T4 to L4 being released when you need to do it. And how pivotal is this transition really? Well, I just point this out in a sense, not egoically here, but we were able to achieve 3 patents on the surgical technique in the last 3 years here. Not to stop others from doing the technique. That's not what this is about. It's about memorializing the development of the technique for the future. And it also points out very significantly that because there is a patent for VBT, the first version. So how different is ASC? ASC is different enough where we were able to achieve 3 separate patents for it, right? And I think that's important to lay out. Going out back to where we are now with this multi-year, multi-generational improvement of VBT, I had presented a similar slide to you in the last interview like this, trying to highlight, well, with ASC, you can do pretty much everything. With VBT, you're very, very selected, very mild curves, growing kid only, and why. And then this slide just highlights that again, that, we can do not just your mid-range curves, 30 to 65, not ones that are flexible or just growing, but certainly curves that are over 65 degrees by far. What happens to the thoracic kyphosis, the roundness of the back? Well, with VBT, it doesn't change at all. We'll look at some slides with regard to that later. And with ASC, it improves dramatically to the fact that it impacts neck position, mature spines, adult spines. And then, well, what's the end result of this for ASC now? Well, our current results are that we get 80% corrections on average. Our revision rate is really low, 2 to 4%. And our success rate is really high, 92 to 96%, using the standards that everyone uses to measure the results in terms of VBT versus metal rod. And when I say 92 to 96%, and I say 80% corrections, I'm referring to curves that are not only in the low end category, but the 60 to 90 degree curves. And I'll show that data as well. And so how does that compare to VBT? Well, VBT is 37 to 55% corrections. There's up to a 30% revision rate. And there's a 60 to 67% success rate. And those are for mild curves. So with that data, if I was a surgeon that was doing VBT, I would take a step back. And that's what's happening right now in the VBT world. People are taking a step back and say, maybe VBT is not what it was meant to be. Maybe what we should do is consider something else. What are they considering right now? Well, obviously the metal rod surgeons that never went to VBT are like, see, I told you so. And the VBT surgeons are, well, maybe we can do something in between. Maybe we can do a metal rod in the thoracic spine and cords in the lumbar spine, the hybrid. I just explained to you that I did the hybrids back in 2014, right? So I want to try to emphasize that point as well. And I would like to come back to that at the end. So when we look at the data, before I get into that, let me just explain to it. So we waited all these years to do this second interview. Why? Because we were collecting the data to prove our point. And so we have basically, when we look at these categories of metal rod versus VBT versus ASC, we have to think of it in terms of who are we treating. And obviously the most common group is that growing child, which does fit a VBT category because it requires growth to achieve some result. But then we have the maturing category, meaning I'm a teenager, but I don't have a lot of growth in my spine left. I don't really qualify for VBT because of that. So what are my options? It's either a metal rod or ASC. And then we have the last data group I'm going to show is our severe category. And that's curves that are 60 to 90 degrees, because there's an interim category. There's the moderate curves with our current technique, which I'm not presenting here. What I decided to do is go for full tilt, present you the data for our current data for 60 to 90 degrees, so then you can extrapolate back, right? So let's just jump ahead into the first category. When we look at ASC versus VBT in a growing kid, and that's because VBT requires that growth. If you remember, we talked about how the spine, when you grow, ligaments stay tight and it starts to spin. And if you're growing, VBT, because of the limitation of the thoracoscopic approach, can only get the curve down so far. You need growth to help pull it in any further. The problem with VBT is it's a unidirectional correction. There's no derotation. It's simply a correction in this plane. So when they do continue to correct, they correct flat. And then they don't get full correction, because with VBT, it's very difficult to get the curve below 30. You might get to 20, 25, but you're relying on growth to do the rest. And if that curve is left at a certain height, 30 degrees or 35 degrees, there's a good chance it's going to break and it's going to recoil because you haven't taken out the internal fork. And so when we look at the data in that type of category, the first thing you can notice is we tried to choose a group that was very consistent across the board for follow-up, for size curve, although our curve was on the higher end of 55 degrees, most were 40 to 50 degrees. What happens in our corrections? Well, we go from our average curve size down to 16 degrees, which is about a 71% correction rate. The others are going down to the 20s, and they have about 54, 50, 37% correction rates, which translates clinically into what? Well, for the major studies that are out there, they report about 74% success rate for keeping a curve under 30 degrees at growth. Somdani reported 80%, but it's really important to note that that study, which was used for the FDA, I believe, was for curves under 45 degrees. They had 80% success rates. But when you looked at the curves that were 45 to 65 degrees, it was 61% success rate. What's our success rate of keeping a curve under 30 degrees? It's 93%. And our revision rate is really low, 4% in that cohort. And this is a cohort that is from about 2015 to 2017. And just to be clear, it's comparing apples to apples. This was single core technique when I was doing that. It's comparing to VBT because that's single core technique. So with our single core technique, adding those releases and the concept of ASC detethering, then we were ending up with low revision rates. But if you look at VBT without the detethering, right, without the concept of derotation, those revision rates are up to 30%. Okay. So what happens if we again go to the next category? So for your mature kids and adults, I mean, they don't have any growth, but they have curves that you're treating with ASC compared to what you would have to do, which is metal rod. So in this category, the alternative is only metal rod surgery. And if you look at this category, again, this is single screw technique. This is going back a few years, so we make sure we had enough follow-up and an average follow-up of 30 months, and that we were treating them apples to apples, single cord screws. Our correction rate was about 65% in that category compared to about 41%. And there's only very limited data here because there's no one can treat these kind of curves in the mature group of VBT very successfully. And the success rate of that VBT group, again, in the 60s, the revision rate, again, 10% compared to 4%. So even in that older group, we were matching results that would, in my opinion, are better than metal rod anyway. If you go back to now to the next category, which is really what we did here, is I went back only just a couple of years where I was doing double screw, double cord technique. And there is no comparative data because there is no one that can do this other than metal rods. And what's the average curve size for this group? Well, it was anyone who had a curve between 66 and 90 degrees, but the average curve size being 75 or so degrees, right? we got those curves on average down to 15 degrees. And so that makes a success rate of 79, 80%. Clinical success somewhere between 92 and 96% by the measures that are used commonly to decide what is a success. And we had 0 revisions. So this data is dramatic. And it's dramatic because this is an average curve size of 75 and ranges from 60 to 90. Not even in the VBT category, not even possible. These are mature individuals, not possible. So your only alternative is metal rod. And so let's go through a few other items too before we switch to some of the examples. I want to talk very specifically about the problem with VBT, or of that first version, and it's that lack of derotation, right? And so if you take a look, I really like this slide because this is a individual with scoliosis from the side, and you see the very clear hallmarks of scoliosis: very flat thoracic spine, very forward neck. Right? You do VBT, you end up with a very flat thoracic spine, and you maintain your forward neck. When you start to consider the terms of derotation and restoring balance to the spine 3-dimensionally, that's ASC, and you end up with this roundness, and you end up with reversing the correction of the neck. And so how does that translate clinically? Well, this is an example of VBT, and you set that flat forward thoracic spine, flat neck, and that's what you see. The side profile is that forward neck, and you have the shallowness between the scapula. So let's look at our data for kyphosis, and that's called kyphosis. So if you're flat, the spine goes in with scoliosis, that's hypokyphosis. And restoring that roundness from the side of the postural round back, that's called restoring kyphosis, right? So normally the individuals have kyphosis that's in the range of, 30 to 55 degrees or so. That would be a normal range of forward roundness so that the neck can be balanced in back. So how did we do? Well, with growing kids, the same categories: growing kids, older kids, and then severe curves, pre-op measurements of hypokyphosis, meaning 11 degrees, so it's below the normal, in that category. In the older kids, it was 2 degrees, and the severe curves, it was minus, meaning it was way in. And so how does ASC affect that? It brings us into normal ranges, right? Going from 11 degrees to 28 degrees for a growing kid, that brings you into a range of normality. And they're still growing. And that's over 100% correction right there, right? Going from 11 to 28 degrees. When you look at the other categories, it's even greater. You're going from 2 degrees to 33 degrees on average. You went from -4 to 34 degrees. That's really rounding out that back. And that's detorquing that spine, which is addressing the true genesis of the scoliosis, which is as you grow, you twist this way. So not even metal rods can effectively do that. When you have big curves, like in our severe category, a metal rod approach would be go to the front first, release the spine, then go to the back, put the metal rods in, fuse it. And what have you done there is destroyed every single disc. So this is what I mean by restoring that roundness in the back. And you can see the fullness occurring, not just the shift of the correction of the scoliosis, but you really see a very nice roundness profile occurring. And so how do we achieve that? And this is going back now several years. We've talked about this. Well, it's the release. What do you mean by the release? Well, it's the release by ASC by Drs ABC. It's how we do the release. It's a release of that contracted ligament. It's a release of that disc. Do we destroy the disc? No, we don't destroy the disc. The whole goal here is to maintain function of the disc. Well, how do you know that you do that? I mean, if you have a metal rod, you destroy those discs. Aren't you going to be causing degenerative change in those discs? So I would say to you, we now have 10 years of results from this, and it's broken down into several categories. Number one, clinically. When you develop discogenic back pain or a degenerative back problem related to a disc, it's a very clear syndrome, and it leads to a very directed workup for that. And what I can tell you from all the 800 patients we've done, we do not see that. We haven't seen it. Okay, so that's one category, just clinical experience. How about when we did our stage surgeries and we send up, so that means I had a really big curve at the beginning, a 90, 100-degree curve. I would take them down to 40, and then a year later, I go from 40 down to further correction. I would have released them the first time, and when I go back a year later, I release them again, which means I'm going to those same discs. I'm seeing that they still have motion, and then I'm sending off some of that tissue to the lab. And what do we get back from the lab? We get disc tissue. Right? So now we have microscopic evidence that there's disc tissue that is maintained. So then what's the third category? Well, okay, If I'm not working up any of these patients, and we talked to this about 3 years ago, if I'm not working up any of these patients and I don't need to actually get an MRI to look at their discs, how do we show it? Well, we went ahead and got some MRIs. We went ahead to assess the disc quality after the surgeries, about a year or so, 6 months to a year later. And so that's where I'm bringing you into now is some of the MRI data. So what we did was we took a few cases. For this is a huge curve, right? This is not something treatable by VBT. If you were doing a metal rod surgery for this, you would have to go from the very top to the very bottom, and you would be definitely going to the front of the spine to release those discs so that you could get some further correction. So this is the ASC result that we had about 10 months after surgery from a 13-year-old. There's some residual, but what we do in ASC, which is what the beauty of ASC is, we're not creating a rigid segment. We're creating a detorsional correction in the spine, which allows for balance in multiple planes. So the concept for ASC is you want to end up with balanced shoulders, balanced pelvis. If you have a residual curve up here, which is significant, even from before surgery, that's going to improve some, and that's going to balance out the residual in the upper spine. So then we strive for neutrality in the waist, right? So anyway, so this surgery required releasing the disc and the ligament at every single level, top to bottom. And what we did is we got an MRI at the lumbar spine here. So that's the L3-4 disc signal on an MRI before surgery. And then these two are 10 months after surgery. And what you see very clearly here is the restoration of that line is called the internuclear disc cleft. And that's a normal signal for a disc. So not only have we maintained disc space height, but we show very clearly that that disc became healthy again, right? And you have to understand, in that scoliosis of that severe curve, that disc is not healthy. In that crux of that corner, the disc is fibrotic, tight, and contracted with the ligament. And so when I release that area, we pay particular attention to not destroying the disc. We maintain the cartilage surfaces and things like that. But it allows the vertebra to open, despin, and then reheal in a new level. And this MRI shows that. It also shows one other important point. This is a lumbar MRI, right? So all the information over the last few, you should only do thoracic disc because they're less functional lumbar. So we went ahead and actually showed you what happens in the lumbar MRI and the lumbar disc. Here's another example. This is a 46-year-old patient. Okay, again, not even in the category of VBT. If you were going to do a metal rod surgery for this, you would be going from up here all the way down. You would be destroying these entire disc spaces with the metal rod so that you would have a rigid segment. So this is the correction from ASC 15 months after, but importantly, every single level is released so that it can detorque and get to the new position and heal in that position. The analogy I have for that, remember, I like my analogies, and VBT is like putting a single anchor on every single tooth and trying to tug on those teeth, but you don't get rid of the torque. So if the cable breaks, it rebounds back. ASC in the VBT category is putting on two anchors on every single tooth, putting multiple cords in, but also before you actually make the switch, you're loosening up every single tooth. You're loosening them up, swinging them over, and at surgery, you hold them with the cables. So that over the next month or two, those discs, those released areas, that tissue reheals in a new position. That's a position over here, not over here. So if the cable breaks, it doesn't rebound. It can, nothing's absolute, but the chances that we've shown is it's in about the 2 to 4% range, not in the 30% range. So that allows us to take steps going towards an older category patient. This is why I'm showing this 46-year-old, because the only alternative for this patient is a metal rod with probably front and back surgery, destroying those discs completely. And so here's the MRI for this patient. This is before surgery, their disc at L3-4. Now, discs in older patients tend to be a little bit more degenerative anyway. This is after surgery, maintenance of the disc space height. And at the level above, you can see restoration of signal and height. And this is in a 46-year-old individual. It's also important to note that the vast majority of degeneration that occurs in disc is normal aging, right? Surgeons, when they talk about, oh, you're going to cause degeneration in a disc, we look at a very select population. If I took an MRI of your back, you would have multiple levels of disc degeneration, as do I. We don't have problems. A very select group of patients will get a degenerative disc, maybe a herniated disc, and get a problem. that patient ends up in a spine office, and then they do surgery there. And most of the time, like I mentioned in my other interviews, you're just plucking out the piece of disc and you're letting the disc heal, right? So even the principles that we already know are true now are being borne out for proof in terms of the MRIs of the patients after ASC surgery. So there's one more of these I'll show, and this is just a 10-year-old. Where, with the 10-year-old, you're allowing for growth. So this is where his curve is at the time. I expect that he'll probably get some improved correction, not a lot, but get some more out of this. But what you do in that 10-year-old, if you really look at the rotation of that lumbar spine, that curve was way out. And so if you're bringing it this way, that's not going to work. You have to bring it this way. And you've got to release those spines so that the vertebra can do that. And then you hold it with the cords and let it heal. And so we know that we went down to L3 here. And so here's the MRI in this 10-year-old, where you can see before the surgery, you can see the signal returning after the surgery at more, and here's the 2 levels that we were able to get the cuts on the MRI for L1 to L2. You can see the restoration of the signal. So now we have MRI evidence, we have clinical evidence, we have microscopic evidence, and we have MRI evidence that it's a better, that the discs do not degenerate. So if you have time, I have a whole bunch of cases I can take you through if you're interested in that. And what we did here was we went back just a shorter period of time, about 1.5 to 2 years ago. Why? Because my technique, the watershed year was 2015 to 16, 17. That's really when we made transitions from single cord screws to double cord screws. And that's when I would say, like, I went from iPhone 0 when we first went to VBT, from VBT right to about iPhone 6. By 2015-16, and I presented those results to you. The severe category results, though, are more recent, and they're the double screw technique. But for this category, I'm now on, I've had to put an analogy to it. I'm on iPhone 13, 14, and we do some really nuanced things to maximize correction. And so that's what this is about. This is about showing you some of these things. So for single curves here, these are all curves that would be in the range of 45 to 50 degrees, so not under 66 degrees. Because I'm going to show some single curves like that and also some double curves like that. But in this category, we're looking at just the mid-range curves. And here's a 21-month follow-up. This is a 43-degree curve or so. We have about a 92% correction from before to after. Importantly here, even though this is a 14-year-old, this is not a VBT case because this is thoracolumbar, goes down to L3. And so the only alternative for this 14-year-old would be a metal rod fusion. What you can see here also is the improvement of the thoracic hypokyphosis, just a little bit more kyphosis, 34 degrees. And you can see that improvement of the neck. It improved by almost 50%, right, from 16 to 8 degrees. And then what does it look like clinically? So here you see the shift in the spine, and you see the fullness coming back into the thoracic spine. We'll just keep going down. Here's another 45-degree curve. Now this is a 23-year-old. No option for VBT, only, even though this is thoracic, it's only metal rod option other than ASC. So with ASC, we brought this down to about 11 degrees. We restored or maintained the thoracic kyphosis here and the thoracic neck profile, 76% correction, and that's the result. Now, what don't you see? You don't see this big incision in the back. You don't see scarred down muscles. And this is also an important case to demonstrate because if you were to talk to a metal rod surgeon today, they would say, well, you're not going to lose very much motion anyway because it's just the thoracic spine. With a metal rod, the metal rod would go to about the same level. But I would submit to you there's a huge difference in this profile after surgery than one with metal rod. There is no large surgery, no muscle disruption to your back, but also in terms of just the shorter recovery, as we all know for these cases versus metal rods. There's some data out there now that is trying to show metal rods don't limit your motion very much. And so what they've done, there's a study out there that talks about flexion and side motion, and it has pretty good results. But that's not normal motion. Normal motion is not two-dimensional in each plane. Normal motion is a rotational phenomenon in every plane. You rotate to the side and you bend, right? And so as much as they want to argue that metal rods doesn't inhibit your motion, if you ever really look closely at movement of a metal rod person, they pivot, they don't arch. And so at the age of 14 or 15, do you really want to do that? Is that patient going to be a college athlete or not? Maybe, maybe not. Maybe they're just a casual dancer, but metal rod changes that forever. If we look here at this next case, this is a 50-degree curve. I showed this one because why? Well, this is going up to T4. This is a really very difficult curve, actually, even though it's just 50. Look how high up it goes. And so I'm very routinely can go to T4 or L4. That we got this down to 8 degrees, again, with the double screw cord technique. And the clinical picture looks like this with about 84% correction. Here, this is a 60-degree curve, again, thoracolumbar down to 18. 69% correction. This is a 30-year-old person, not a 15-year-old, not a kid with growth. And this is what it looks like after the surgery. Again, trying to round out that back, and in addition to creating the trunk symmetry. This is a 55-degree curve down to 1, so it's a 97% correction. And in a 17-year-old, so again, maturing group. This is what it looks like. And here you can see just a little bit of that tag because I make my incisions vertical on the side. All right. And so again, none of the back muscles get disrupted.
Dr. Antonacci, can I ask a question?
Yeah, sure, absolutely.
It's pretty impressive how you can get double screws so high up into the spine. Because I've talked to many spine surgeons, and they always quote the small dimension of the thoracic vertebrae, the softness of the vertebrae. How do you do it?
Good. So, well, you have to adjust per case. So even in this case, T4, but there's only a single screw in T4, single screw in T5, and then doubles the rest of the way. And again, you're also speaking to people that only work through a scope for VBT. They have trouble putting in a single screw. Right, that's different than the technique of ASC, which allows you to really delineate the surface of the spine and see the segmental artery and see the nerve and be safe about it, right? And that's what allows you to do this.
Can you talk about the why keeping the integrity of the segmental artery is important?
So at every level of the vertebra, there's one artery on each side of the spine that supplies the spinal cord. And if you disrupt both sides or at multiple levels, you can cause paralysis, right? So it's the blood flow, just like going to the brain, it goes to the spinal cord. And so the more you can save, the better. There's been studies back from the 60s and 70s with metal rods that you could sacrifice almost every single one on a single side and people will be okay. But what we noticed is during a surgery, when you do that, you'll get some changes in signal more often on your neuromonitoring. So even in the early days, 9 years ago, when I would sacrifice most of them, people did fine, very safe surgery. But during surgery, you would get changes in signal because the spinal cord is adapting to that sudden change in blood flow. Once I started saving the segmental arteries, and with ASC, you can save the vast majority most of the time. So when you do that, you hardly ever see signal changes. So we know that we're not even impacting on a subclinical level, right? So clinical level is actually you see signal changes and there's a deficit. That's extremely rare. People, especially with ASC, I now tell families that the chance of something bad happening with ASC is so rare that I wouldn't worry about it, right? So I don't go into surgery with ASC worried about that patient medically. When I did metal rod surgeries, I went into surgery thinking about that medical side and also what I had to do technically. We've done 800 of these surgeries, and if we've transfused 5 or 6 and 10 people at most, right? Now, if I had done 800 metal rod surgeries, about 600 people are getting transfused, right? We've done 800 surgeries and we haven't had a significant infection. If I had done 800 metal rod surgeries, we probably have 1 or 100 infections, right? So it's huge surgery. Revisions for metal rod are even larger than the first surgery. It takes you a year to recover from the first surgery. You never get your normal motion back. And then if something happens like a broken rod or infection, you have to redo that whole process. Right? The vast majority of ASC patients are going back to school around 4 to 8 weeks and going back to sports around 6 to 10 weeks and going back to competitive sport at 3 months. That's just night and day difference. And that's why I said we're at a threshold moment. We're at a moment where there needs to be a behavioral shift in the treatment of scoliosis. It will be towards ASC as this data becomes more solidified and out there, but it's a process. It doesn't happen overnight. It's been 10 years now that we've collecting this data, even for you, right? Showing you where we were in 2015, where I explained to you we were in 2020. and here. So even in my own practice, it's taken us 10 years to get to the point. Now we're at the point where people need to learn this procedure. And it also goes back to another point. Well, why are people doing VBT? And this is where the instrumentation factor comes into play. There's two companies that produce it, Zimmer and Globus. Those are just the metal rods that ends cords are very similar to pedal screw metal rods that we use, right? But Zimmer was the first company to get marketing approval for saying that they could use this instrumentation for VBT, right? It was based on the very early studies. And people need to understand, what does that mean? It doesn't mean a doctor can't use another company like Globus or Zimmer to do VBT or ASC. What it means is a company can promote it. So how do they promote it? They start putting on weekend workshops so that they can say to this doctor in Iowa, well, come for the weekend. We'll show you the instrumentation. This is the technique manual for VBT, and we'll show you the instrumentation and you'll learn how to do it. Okay, now I'm going to start to go back and maybe try to do VBT, right? Based on a weekend. Okay, and then also those type of situations require, we talked about this last interview, a thoracic surgeon to help them, because the vast majority of these people, metal rod surgeons, they don't work very much in the front. They always work in the back. And so if they're going to start migrating to ASC, they need to get a thoracic surgeon to help them do that. So these are big steps that have to be overcome, but that doesn't mean the endpoint of ASC is not the way to go. In my mind, ASC is the only treatment for scoliosis, except for very rare situations, and they are there. ASC is not, it's not one fit size all, right? You know, there are going to be cases even today that require a metal rod, but the vast majority of common scoliosis, it should be treated with ASC. And what's the difference between now and 5 years from now with ASC? Well, the difference is we're just getting better and better tools to do, but the principle is the same. Just like for metal rod surgery, we really haven't changed the principle of metal rod surgery for 20 years. What the principles were in 1995 are the same exact principles today with metal rod. What's different? 1995, there were 20 companies. 2023, there's 150 companies. And that's the difference, right? So it's not the principle, and the principle ASC now is very clear, and it's, in my opinion, much superior to metal rods. Let's jump to double curves here. Double curves, again, this transition for us around 2014, 15, where we started doing the lumbar side. But these results are from much more recent, so you can have the modern technique. But again, these double curves are all in the range of 45 to 65, under the 65 degree mark. So here's 43 and 53. This is a 14-year-old. More likely than not, the only option for this patient is a metal rod from here to here, and or ASC. This is the ASC result, where it's down to 8 degrees and 9 degrees, so a 78% correction. And you can see really nicely, this was 16 degrees of kyphosis going to 7 degrees of lordosis, actually reversing the neck. And that's because we went from 16 degrees in the thoracic spine to 34 degrees of roundness, right? And you can see that result here. Here's another case, 61 and 45 degrees, very flat, very forward. And you can see the front correction, which is great, but you really see how we round out the back here, 32 degrees from 11, and that really helps that neck balance. And so we have an 83% correction overall, 17 months after surgery, and this is what it looks like. And here, this is a beautiful example how you really round out that back, in addition to maintaining the symmetry in the waist, or achieving the symmetry in the waist. Here's another example. This is clearly a very dramatic lumbar type curve, more so than the thoracic. Again, in a 14-year-old, forward pitched neck, 6.5 degrees. After the surgery with ASC, clearly corrected dramatically down to L4 with about 15 degrees of lordosis and an improvement of the thoracic profile. I put L4 here again. Why? We started routinely going to L4 in 2015 or 14 even. And that was a technique that we developed because prior to that, it was considered unsafe going to L4. A lot of that surgery was done from the side for lumbar adult degenerative disc disease, and L4 was always risky with injuring the L4 nerve root. We developed the technique where we routinely go. We haven't had a single nerve root injury from that. And so that developed early on in 2014. Right? This is the profile. Again, a very nice roundness through the back, symmetry, and an 85% correction. So now we'll go to some of the complex ones. And this is maybe beyond the average viewer here, but these are curves that are high, 66 to 90 degrees, either single or doubles. We'll get to both. This is 81 degrees down to 20, the 12-year-old. There's some growth remaining in this individual, so hopefully they'll correct a little bit further. But even if they don't, balance, and neutral. And we look for that being the 75% correction, and this is the result. Here's a 94-degree curve. It's so high that we have to do it in 2 measurements on our radiology system, but it's 94 degrees, very severe upper curve as well. So got that down to 22 with releasing every single level, derotating that spine. So now we have balance above, balance here, level shoulders, level pelvis, and significant improvement in that neck profile as well, 76% correction. And this is what it looks like clinically, 19 months after surgery. And you can go back and say, well, what happens if the cord does break here, right? We're 19 months later. We've done dramatic work on an 94-degree curve. If this cord breaks right here, which it could, we can go revise that. It can be changed. The cord can be changed, unlike in VBT, right? Or metal rod, which is permanent. You can go back like braces on your teeth, take out the old cable, loosen it up again, and correct it even probably down below 22 degrees. The likelihood if this cord breaks, though, it will only migrate up to about 27 or 28 degrees, which is not an indication for surgery anyway. But if it did rebound, we can revise it. How do we know? Because we've staged surgeries and we've done them, right? So again, that understanding out there, if you went to a VBT surgeon and said, well, cord broke, what are we going to do? They would say, we have to convert it to metal rod. I think I told you back then that I never converted one to metal rod, and I still haven't, right?
Dr. Antonacci,
Yeah.
with revisions, with respect to revisions and going back into the chest cavity, because VBT surgeons indicate that there is scar tissue that kind of forms around the lung, and sometimes it's pretty tricky to revise just because of some individuals have more scar tissue than others.
Yes.
Do you find that to be a problem?
Not at all. And the reason for that is you cannot revise a case with a thoracoscope. So they go in with their camera the first time, the thoracoscope, that scoring is normal with my process as well as their process. But when I go back and I do the mini open approach, I can see all that and I can take it down like trimming a haircut. I personally actually find revisions easier sometimes than the primary, right? And I would also tell you that the recovery for a couple of things about revisions. There's no increased more blood loss, right? So it's not like we're giving revisions transfusions compared to non-revisions. That's unlike metal rods. Metal rods almost guaranteed revision. You're going to get transfusions. The recovery for a revision is very similar, if not faster, than the primary ASC case. So if a kid has surgery 4 weeks and they're feeling like going back to school 4 to 6 weeks, and we release them for sport at 6, takes them a few weeks to really get back to their sport. And certainly if it's competitive, it's a 3-month process to get back their competitive win back for a high-level athlete. But if that was a revision, they might feel up to that at 6 weeks going back to their sport at a more competitive level. It's just a little bit faster on the revisions, right? So we have not found any difficulty doing the revisions.
Excellent. Have you been tracking any issues with lung function post ASC, post revision?
Yeah, so that's probably an area we have to document, but it's not like we don't track it, right? And so I think I alluded to this anecdotally last time. And if you have your competitive athlete who's a track star, basketball player, this, that, they all pretty much say the same thing. I felt like I could start training at 6 to 8 weeks. I was starting to train, but I really didn't have my competitive win back until 3 months. Right. So that's the vast majority. And so we know clinically that the lungs are doing just fine. And again, that's an understanding that we don't damage the lung by this surgery. Never did. VBT doesn't either. And so you're just working in the plane between the lung and the chest. So that's like letting the air out of a tire, letting the inner tube down so I can work on the hub. And when we're done, we just blow the tire back up. Right. There are some situations where you do get some scarring between the wall and the lung, but almost always it does not lead to an impingement of the lung function. we just jump down to some complex of the double curves. Here's a 67-degree curve. So again, rather high. It would be a metal rod surgery, 76% correction. This is what it looks like. And again, you don't see those incisions. Well, you see a little bit of a tag right there, but pretty much, your back is pristine, right? Here's a 75-degree curve, 58 lumbar, with a very flat back, getting it down to 26 and 19 with balance. So 26 here, neutral through the waist, level pelvis, level shoulders, nice roundness in the back, 65% correction. And this is what it looks like clinically. Here is a 70-degree 67 in a 12-year-old. Have to watch this 12-year-old, make sure they don't overcorrect, because that can happen. But most of the time when we're doing our 12-year-olds, we check everything by hand score. So we kind of know if they have a lot of growth left or they don't. Really nice correction of the neck, though. Look at how flat this spine was before surgery, 10 degrees. We rounded it out to 26 degrees by derotating it. And that neck went from a positive 20 kyphosis down to a negative 3.4 lordosis, which is fantastic. And that's her correction, right? About 74% correction 18 months after surgery.
Dr. Antonacci, what happens with hypokyphotic or flat back or even lordotic thoracic curves that are a little bit more rigid into flexion? Those are pretty tough to even get a kyphosis correction on, aren't they? What do you do with those cases?
So the curves go in and rotate, and then what you're talking about is what happens when it gets large and stiff, and we can't. So that's where releasing every single level, really circumferentially releasing that to try to get as much correction as we can. There are some cases that we are currently working on where we may actually have to. There's situations where we're talking about the 95-degree curve, where they're so over and forward that we can get them partially corrected here in a nice, I call it the yellow to green zone, but they're still forward. And we may consider at this point adding a little spacer in front at 1 or 2 levels to help jack it back. So again, that would be iPhone 16, right? So, but that's what I mean. We're getting to the point where 95 to 98% of all curves you come across are going to be treatable by ASC.
Okay, so you're actually saying that you might, in terms of a spacer, you might put a cage in where the disc is and tether around that,
right? Especially in the thoracic spine, because we don't require motion as much in the thoracic spine, and you're not fusing multiple levels. You're maybe fusing just 1 or 2 levels, and the rest is all mobile, but you put it into better balance so that the requirements on the cord above and below with all the other releasing is not impacted in a negative way, because you addressed, that would like having a brick wall where the mortar is bad at 2 levels in the middle of your first floor. And you say, well, the mortar is really good at all the other levels, but maybe if we just go to those 2 levels and regrout, take it out and regrout and solidify that level, now we can work above and below that really effectively. This one's a great one to look at because it's such a huge lumbar curve with a lot of rotation. And this 15-year-old brought down to about 6 degrees. Again, you can see how the restoration here really impacts the upper curve. Look, because that curve goes in and it's rotated, they really do go forward and stay flat. And when you pull that spine back into them, it allows the spine to balance, right? So you see the impact of this lumbar curve on this upper curve. That was almost a 90% correction. And that's what it looks like clinically, right? I think there's only one more. So, but here's, again, this is a 100-degree curve in the thoracic spine in a 14-year-old, where clearly you have to do a lot of releasing and like you were talking about, and how effective can we get it now? Well, we've got a 100-degree curve down to 21. That's almost an 80% correction. And that's by releasing every single level. And so clinically, be hard to imagine that you could get a 100-degree curve to look like this with ASC 10 years ago, right?
You mentioned that over the last couple of years that you kind of progressed into using triple cords and quadruple cords. Can you touch on that a little bit?
Yeah. So, it's just again, continued migration of improvements. So, in terms of trying to make sure that, it's a wear and tear phenomenon why cords break. right? It's an abrasion. It's a material. It's up against screw corners. Just a piece of paper can be torn on a kind of a curved surface on a counter, right? If you do it the right way, or if you do it repeatedly, eventually the paper will cut. And same with the cords. The key here is maintaining stability in the spine, or achieving that, so that even if the cords break, it doesn't lead to a rebound. And that's the releasing philosophy. That's the detethering philosophy. That's why I have that pet peeve is I'll never call it a tether. It's a cord, right? And so what do you do with belts and suspenders? Well, we start considering putting more than one cord in each screw line, and that amplifies the strength. It's kind of like working on bridges where you have multiple cables across versus just a single cable. And it's really principles like that, and we've had good success with it. We've noticed certainly that the more releases I've done, the better correction. The more cords I've used, the better the strength of the correction, and it's nuances like that. Even the transition zone, when I said we have a quadruple screw transition zone, that's where the T10 to T12, when you have a double curve, is how well are you controlling that transition, right? If you really think about it, we really like to control that really strongly so that we can migrate, we can correct above and below, but relative to that intermediate space of T11-12 or T10-11. And so how I capture that, that's going back to that original slide, like in 2013, it was not overlapping. I mean, we had one screw on one side, one screw in a vertebra below on another side. Then in 2015, we actually did it in the same vertebra. Now maybe we're capturing multiple vertebrae, and maybe with multiple screw patterns, right? This is the genesis of these patents, right? So all these nuances have been captured and memorialized, because this is the pivot point where people need to wake up and start realizing what they're offering. And if they don't know how to offer, they need to start learning.
Have you noticed that in terms of flexibility? Because I know going from 1 to 2 cords, you do lose flexibility, especially lateral bending. When you go up it to 3 and 4, you notice a reduction in those.
Not clinically. So not clinically, meaning these kids still go back to their gymnastics with good range of motion. And often you have to understand, when you have that curve, that scoliosis and that angled waist, what you're doing is you're bringing them to the midline. On top of that, it's not a two-dimensional motion, right? So you're not just bending this way and bending this way. If you looked at it directly like that, then those cords would impact that. But that's not how the spine rotates and turns. It rotates and it turns, and it rotates and it turns. And that doesn't get impacted as much by the cords.
Okay. Now it's been 2.5 years since our last interview. And one of the questions at that time was basically, if a tether breaks, especially for more mature adults, and if there's regression in the curve, have you noticed any more data in terms of supporting that? How long the cord has to maintain stability before it or just less?
So that's that's an educated guess, right? And my educated guess is just a few months. This is not like a year later, 2 years later. That when I release that tissue, it's like cutting your skin. How long does it take for your skin and multiple layers in your skin to heal? That's the same idea. Or with your tooth, if you loosen your tooth and move it, how long does it take to heal? It's only a few months. It's not, now it will continue to remodel and things like that for a period of time, but that initial repositioning and healing occurs within just a couple of months. So I showed you some of those MRIs, right? Mm-hmm. Some of those MRIs were just 6 months afterwards or 10 months afterwards, completely normal disc looking. So certainly by then it's actually rehealed.
Okay. I have seen some MRIs from some ASC cases from other surgeons, right? And there seems to be some evidence of the discs basically being degenerated, some autofusion, some degeneration of the vertebra above and below. What kind of separates your particular disc release technique from others?
I don't know. I don't know what they do.
Sure.
I know what I do.
Not a fair question.
And it is about maintaining integrity. And so then as much integrity as possible. And there is a difference. If you have a 100-degree curve, right, you may actually naturally autofuse just a few at the middle of the curve, even with a flexible technique of ASC. But it doesn't matter. I mean, you just took a 100-degree curve and took it down to a range where everything else can still be mobile, but you're anchored in the middle, just like that transition zone. So that's part of it. And so there might be very certain, particular type cases where there might be some autofusion occurring right at the apex where that curve was maximally corrected because it had to go to bone just to get the correction. But all you've done is stabilize it further so that the rest of the levels can move, right? So that's one area. But it's then you just have to ask yourself that the older question there, the more basic question, what's the alternative for that one that you were just asking about? The alternative for that surgeon raising that question is to destroy the disc at every level and do metal rods.
Yes, because I get this question all the time from viewers and from those with severe curves, is that, well, why shouldn't I give ASC a shot? Because with fusion, there's no taking it back. There's no way of doing it, right?
Correct. And we're not saying here that ASC is the perfect procedure yet, right? But what we're saying is the results are better on average than the metal rods, and leaving you with more options and correcting your spine with better balance, right? So
2 follow-up questions, and I'll let you go. For more mature adults, getting into 30s, 40s, 50s, does degeneration of facet joints, degeneration of this vertebra, does that limit what you can do with ASC?
Yeah, so I think the oldest patient is 53 when I did her surgery. And I haven't gone above 53 to 50. I think the oldest is 53, and but certainly in their 40s and 50s. But the assessment in that situation is how flexible are they? And then also, are those joints in the back, as you alluded to, arthritic? Because I don't care if you have really arthritic joints, but a very mobile spine. If you bring them into the middle and they're very arthritic joints, they're going to be painful arthritic joints because they're still moving. So that's the assessment. It's like, how arthritic are the joints to the point that when you move them into a new position, will it create pain or not? And so that's why I think the category for ASC is probably in the 40 and early 50s. Getting into anything higher than that is really going to be a detailed analysis of facet joints and things like that.
Now, your youngest patient, in terms of ASC, is, I believe, 5 years old with early onset scoliosis.
Yeah.
Can you talk a little bit about?
So that's a whole nother category of patients, right? It's not the mainstream. It's early onset. I think we've done about 10 to 15 of them. What I learned over the last 10 years is to release even them. So again, they're the perfect release, because if you don't release them, you're just torquing on it and you're expecting them to remodulate it, but they don't necessarily. They have this internal growth mechanism that's forcing this curve. And so I would say that it's even more important. You don't have to do a lot, but you have to release that disc at every level so that you bring them down to about a 30-degree, 40-degree range. And then you're going to go back in about 2 or 3 years because they're going to grow, but they're going to stay in. I describe it to patients like that. Right now, at 5 years old, they're in the red zone, right? We have to do something. What I want to do is bring them into the border of the green and the yellow zone, right? So we're going to bring that sapling tree that's growing off to the side, swing it closer to the fence, not perfect to the fence, but close to the fence. And then we're going to do this with the cords, and we're going to see. And then around 2 or 3 years later, you have to go back, readjust it, you might release it again, put new cords in, because now they're going from the 8-year-old to the 12-year-old, and we have to watch that. We're just trying to keep them in that yellow-green zone. And then when they're 14, 15, put them into the green zone.
Okay. Now, you haven't taught any surgeons your technique for about 5 years now. Are you?
COVID really hurt.
Okay.
I was doing it. I think I operated in 8 countries before COVID, and then COVID stopped it for 2 years, 2.5 years. I'm going to Prague this summer to go give a talk, and so we're starting the process again. It's just like I said, it doesn't happen overnight.
Absolutely. Okay. Do you have any final parting words?
Oh, going back to that hybrid situation, nothing bothers me more than these surgeons recommending a hybrid, because they're recommending the hybrid because they can't adequately treat the thoracic spine with VBT. So they're thinking that, okay, let's get some motion maintained in the lumbar spine by doing the metal rod and the cords. Without the releases in the lumbar spine, that's doomed to failure almost, because not guaranteed, but it's likely that those cords are going to break because you can't restore the three-dimensionality to the spine and get it to a position of balance. If you're doing ASC technique, you would have a higher chance of doing that. But then if you're doing ASC technique, I can treat the thoracic spine by ASC too.
Thank you so much for sharing your time and bringing us up to date.
Thank you. I really appreciate it.
We'll have to do this again in another 2 or 3